The final chapter in immunology is immunosuppressants. So typically we use these when we just talked about transplant rejection. We typically use immunosuppressants to suppress the immune system so that we don't reject organ transplants. So that's their commonplace. So the first one we'll mention is cyclosporin. And before we start talking about this, we have to talk about the normal signal. So the normal signal to stimulate an immune cell, interleukin-2 and other stimulatory cytokines, let's say that this is a T cell, stimulates a growth factor receptor that then stimulates downstream effects such as cyclophilin, calcineurin in turn is stimulated, and then NFAT is like the on switch for this immune cell. It acts as a transcription factor for synthesizing more DNA and other cytokines and other stimulatory molecules that can go and stimulate other immune cells. So what cyclosporin does is it actually binds to this original and this starting stimulatory downstream mediator. So it binds to this cyclophilin and inhibits it, and thus inhibits the whole downstream effects of NFAT and transcription factor regulation and synthesis of stimulatory cytokines. So you knock off the first one, you knock off the whole thing. All right, the major side effect, as you see here, is kidney toxicity, renal toxicity. So know that. That's really all you have to know for cyclosporin. The next one is tacrolimus. It acts very similarly to cyclosporin. Here's the normal progression. We have cyclophilin stimulating calcineurin, and then NFAT is like the on switch. So what tacrolimus does instead is it actually activates a protein called FK binding protein, and this inhibits cyclophilin instead of cyclosporin. So very similar to cyclosporin, except it's FK instead of cyclosporin. So there you go. Same downstream effects and same kidney toxicity. So the next one is sirolimus. This acts a little bit differently. So a different receptor, a tyrosine kinase receptor, kinase implies phosphorylation, is inhibited by the sirolimus. So the mTOR pathway in the whole MAP kinase cascade, which is involved in cell proliferation, this is inhibited by sirolimus. All right? And we don't have MAP kinase, we don't have cell proliferation, and immune cells need to proliferate when they need to respond to pathogens. So this is how we inhibit the immune cells this way. The thing about sirolimus is that the kidneys actually survive. So that's a way to remember it, is kidneys survive sirolimus. So SIR and SUR. Sounds similarly. All right, the next one is basiliximab, and this actually binds directly to, it's an antibody, okay, a monoclonal antibody that we make in the lab and then inject into the bloodstream to inhibit directly the interleukin-2 receptor. And thus, none of the downstream effects can take place if we just directly inhibit the receptor. So that's how that one works. Moving right along to azathioprine. Azathioprine actually is a metabolite that turns into 6-mercaptopurine. And this intercalates into DNA and actually inhibits immune cell proliferation this way. So that's that mechanism. Glucocorticoids are like the chief immunosuppressant medications. We always give them to suppress the immune system. And so I'll mention them last, but definitely not least. So another name for them is cortisol, or just steroids in general. So what they do is they actually inhibit the chief signal, this chief activator and on switch for all immune cells, and that is NF-kappa beta. So NF-kappa B or NF-kB. That is like the ultimate on switch for immune cells, and that's what glucocorticoids inhibit. It's the final nuclear transcription factor for all types of stimulatory cytokines. So if we inhibit that, we inhibit all of immune cells. That's why it's so important and so commonly used in the hospital. Next one is muromonab CD3 or OKT3. It's a really fancy term for just an antibody that directly binds to T cells. So if you think of T cells, they have the receptor CD3, correct? It's another name for T cell receptor. So that's where this thing gets its name, is it basically binding to CD3, which is specific to T cells. So it inhibits T cells. Okay, flash quiz time. Which immunosuppressants can lead to renal dysfunction? So think about it. And the answers are cyclosporin and tacrolimus. Recall that with sirolimus, the kidneys survive. So here's a nice review or summary slide of what we just talked about. So I'll list things here, or I'll show them, and you're going to tell me what inhibits them. So first of all, what directly inhibits the receptor? Directly inhibits the interleukin-2 receptor. It's that monoclonal antibody basiliximab, right? All right, what about the MAP kinase cascade? What do we say inhibits that? Sirolimus. And do the kidneys survive? Yes. So no effect on the kidneys. All right, very good. What about cyclosporin and tacrolimus both inhibit this cyclophilin calcineurin NFAT cascade, but how do they do it? Cyclosporin directly binds, right? And tacrolimus activates what proteins? The FK binding proteins. Very good. And what inhibits NFKB? What is the ultimate or chief immunosuppressant? Glucocorticoids, right? They inhibit the on switch of all immune cells, which is NFKB. Okay, so time for the final section. And this is really dealing with what cytokines actually stimulate specific types of cells. So I'm going to list a cytokine that we can synthesize in the lab, and you're going to try to tell me what cells will be stimulated. So the first one is aldesleukin. And can you guess what this stimulates? I'll give you a hint. It acts just like interleukin-2. So what cells have interleukin-2? T cells. So all types of T cells will be stimulated. Very good. Erythropoietin or epoietin alpha. What is that going to stimulate? So you think of erythrocytes. So it stimulates red blood cell production in the bone marrow. Very good. Filgastrin and sargramostin. Well, I'll give you a hint. These act just like granulocyte colony stimulating factors. So they stimulate granulocytes. So anything like neutrophils, basophils, eosinophils. So that's that. Moving on to alpha interferon and some of the interferons. Well, we talked about them earlier. What do they do? What do they help us with? They help us keep viruses at bay, right? Right. So here we have a virus here. And how do they do that again? So they actually increase an enzyme, like ribonuclease, that degrades and tears up the DNA and RNA of viruses. Pretty neat. Also, what do? They increase a receptor on the surface of cells that presents viruses. What is that receptor? MHC1. So it's kind of like a giant highlighter. That's what interferons are. They're highlighting all the cells that are infected with viruses or that are malignant because they increase the receptors that present them. So then the immune cells can see them more easily and then attack them. All right. So beta interferon, just know that this is associated with a particular disease, multiple sclerosis, so it helps keep the cells, the immune cells that are responsible for multiple sclerosis at bay. You'll learn about that later. Opralvucan and thrombopoietin do the same thing. So thrombo, what do you think of when you think of the word thrombo? Think of thrombus or clot. So what is responsible for clots? Platelets. So these two things increase the synthesis of megakaryocytes in the bone marrow and ultimately platelets. Pretty neat. Therapeutic antibodies you'll learn about as you keep reading through first aid. It's kind of a laundry list right here, but just in general know that they can target specific cancers, autoimmune diseases, and many other diseases. So very similar to how that one antibody inhibited interleukin-2 at the receptor, can also inhibit specific types of cancers, okay, and other types of diseases too. So just know that and keep that in mind. All right, time to test your knowledge on immunology real quick before we finish. So, here we go. A 14-year-old boy presents to the physician with recurrent pyogenic infections. Physical examination shows that the boy has pruritic papulovesicular dermatitis. Laboratory tests showed low serum IgM and a normal serum IgG level. Which of the following laboratory abnormalities is most likely to also be present? So right off the bat, what do you think this kid has? He has some skin lesions. So okay, that's most likely consistent with eczema. All right, he has recurrent infections. The only thing he's missing of this triad that is consistent with his immunologic deficiency is a T, thrombocytopenia. So what is this disease? This is Wiskott-Aldrich syndrome. And you remember this triad of Wiskott-Aldrich? Thrombocytopenia, recurrent infections, and eczema. You remember the mnemonic we used? It was that cat, Whiskers the cat with a bow tie, and he drank all the milk. So low IgM for low milk. So that should be helpful. What about some of these other answers? What about hypocalcemia? What deficiency is that? That is associated with possibly DeGeorge syndrome, okay? Because there aren't any parathyroid glands, so you have low calcium. Or low IgA, possibly that selective immunoglobulin deficiency.
So this test yourself question, which is very similar to what you'll be asked on the USMLE, is a review from the pharmacology section of the first aid text. So here's the case. A 25-year-old day laborer on a fruit farm is brought to the emergency department by a coworker because he is having diarrhea, difficulty breathing, elevated heart rate, elevated blood pressure, and mildly elevated respiratory rate, but his temperature is approximately within normal limits. On examination, he is diaphoretic, drooling, and unable to answer questions coherently. What should the physician give him to treat this condition? So if this is not ringing any bells already, it should. This is the classic dumbbells symptoms that is seen in acetylcholinesterase toxicity. We see this often in organophosphates that are on preservatives for fruit, hence the day laborer. And so the mnemonic is dumbbells, which is DUMBELLS, and it stands for, D is for diarrhea, as we see here. It's basically all of the sequela from too much acetylcholine. So the organophosphate, which is in pesticides, inhibits the acetylcholine from being degraded, and it accumulates in the bloodstream and leads to all of these effects. So, as you know, acetylcholine stimulates the bowels, hence the diarrhea. It stimulates the bladder, hence the urination. And it contracts the pupil, hence the meiosis. The next B is for bronchospasm, because acetylcholine constricts all the bronchioles. The E is for excitable skeletal muscle, because as you recall, there are nicotinamide receptors that are stimulated by acetylcholine. And the double L's are for lacrimation and lethargy. And finally, the S is for increased saliva. So all of these things can be predicted by too much acetylcholine. So what do you think will be the remedy in this situation? The answer is pralidoxime, which helps degrade the acetylcholine and inhibit and competitively bind for the acetylcholine receptors.
Well, that's all for immunology. Stay tuned, folks, for the next pathology section.